Good evening, everyone. Can you hear me okay? Yeah, great stuff. Brilliant. Welcome back. The reason why I have been away is that we've been running a course for the FRCR, and that finished last night. So I'm going to now start teaching every Monday and Thursday, and I'm going to do that right up until we do our next course. And the format of the course for those people who've not been here before is that I'm going to go through lots and lots of Viva films, um, typical Viva films that you might see in the exam. But clearly, some of them might well be long cases, and some of them might also be suitable for rapid reporting. So what I'm going to do now is I'm just going to um, record
Recording in
this to the
progress.
computer for one of my colleagues, but this is not for general recording. And anyone who has any questions, put them into the chat, and also any comments at all. So when I encourage you to answer the questions, just put them in the chat. That'd be great. Okay, the first thing I want to say is the chess course that I've developed is quite comprehensive. I've still got a few more videos to add, but the link is going to be in the chat. And the link is here. And I will keep on putting the link in as more and more people enter the webinar. Okay, so let's go to the first case. This is an elderly gentleman who presents with a sudden onset of abdominal swelling. What's the diagnosis? Yeah, rectus hematoma. And you can see that the rectus hematoma is limited by the midline, and there's the linea alba, and this is the linea semilunaris, and this is a hematoma within the sheath. Now, almost invariably, these patients are going to be on anticoagulation, and this patient was indeed on anticoagulation. If you ever feel tempted to drain it, don't, because that will just introduce infection. And somebody said desmoid tumor. Well, it could be, except that this has come on suddenly. So you've got to listen to the patient, and the patient will give an acute history. Now, here's an interesting one. 84-year-old male with acute abdominal pain. Tell me what drugs this patient is on. Yeah, they're on anticoagulation. Now, somebody's commented that my voice is weak. Is that everyone's experience, or can you hear me clearly? Sound is okay. Okay, that's good. Good, good, good. Okay, so whoever thinks my voice is weak, you may just need to alter the settings on your own laptop. Okay, yeah, so this patient has got an abdominal wall hematoma, probably of transversus abdominis, okay? And they've also got an enlarged left atrium, and they've got gynecomastia. So my guess is that they're on digoxin and warfarin for atrial fibrillation, and we've got the gynecomastia, and then we've got this spontaneous abdominal wall hematoma. Okay, this is a patient who is acutely breathless. Tell me more. Any thoughts? What's the cause of the patient's breathlessness? Pulmonary edema, yeah, pulmonary edema. And anything to note about this particular patient? What do you think about the limbs? Yeah, patient's got achondroplasia. They've got rhizomelic dwarfism. And rhizomelic dwarfism implies that the humerus in the upper arm and the femur in the leg are short. Okay, so rhizomelic dwarfism, the proximal bone in that limb is short. Okay, and this patient does in fact have achondroplasia, and this is pulmonary edema. Okay, this patient is complaining of lower leg pain. Any thoughts? Yeah, osteomyelitis with a Brodie's abscess, and we've got periosteal reaction, typical of osteomyelitis, and the fact that we've got a permeative lucent defect suggests that this is a chronic or an acute on chronic osteomyelitis. Marked soft tissue swelling, and there's the CT scan showing this periosteal reaction, and there's the MRI scan which shows a sinus going through the cortex of the bone. Here's the abscess, and this is clearly a Brodie's abscess in a patient who was an IV drug addict, actually, although it would look like this even if the patient wasn't a drug addict. Okay, abdo pain. Tell me more. Yep, cecal volvulus, well done. So the cecum has flipped over. There's the stomach. There's the cecum. There's dilated small bowel. And the cecum should be in the right iliac fossa, but it's flipped over. And the other important sign here is that if it was a sigmoid volvulus, you would undoubtedly see dilatation of large bowel, the descending colon. Yeah. And so the sigmoid volvulus overlaps the dilated descending colon. That's called the left flank overlap sign. And because that is not present, this is obviously a cecal volvulus. And we've got a video here. There's the cecum. This is all small bowel dilatation. You'll notice in the right iliac fossa the cecum no longer exists. It's flipped over. And there's the twist. So if I just go back, you can see there's the twist. A wall of, it's a whirlwind kind of sign, really, of a cecal volvulus. Okay, what have we got here? Got a pacemaker with a lead in the right atrium, a lead in the right ventricle. Anything else? What do you think about the acromioclavicular joint? The shoulder is not dislocated, but there is some erosion of the left acromioclavicular joint. Okay, so the AC joint on the left is clearly eroded, and you can see it just here, so just there. and this patient has got erosion of the sacroiliac joints, and one of the causes of erosion of the sacroiliac joints is hyperparathyroidism, and in this case due to renal failure, which you can infer by the small kidneys. And you can just make out that there's possibly some end plate sclerosis, possibly a rugged Jersey spine there. Okay, so this is renal osteodystrophy. Here is the erosion of the outer end of the clavicle. Could that be a VP shunt, or could it be a peritoneal dialysis catheter? Well, it's actually a VP shunt in this patient, which is not related to the renal osteodystrophy. Why is it a unilateral clavicle erosion? Well, it has to start somewhere, and then maybe, in a few months' time, it will develop in the left clavicle. Okay, what I want to know is, where are those lesions? Are they in the lung? Are they on the skin? Or are they in the bone? And how can you tell? Yeah, they're in the bone, aren't they? Because if you look at each of these lesions, you never see them in the diamond that is projected between the bones. You only see them where bone is crossing bone or bone is on its own. And in fact, if you look more laterally, you can see that these are bone lesions. And these were sclerotic metastases from a prostate cancer. Okay, so you can work it out in the exam by understanding what you need to uh, assimilate to work out whether it's in the lung, whether it's on the skin, whether it's in the bones. And this was sclerotic metastases in the bones. Okay, this patient has not got small bowel or large bowel obstruction, but they've been anxious and they've been swallowing gas. But there is another finding on the film. So this is called a meteoristic bowel, which implies that they've been swallowing gas because they've been anxious. Yeah, lesion left proximal femur. What do you think that might be? It's actually an osteochondroma. Okay, there's an osteochondroma just there. And there's also an osteochondroma on the iliac blade here. So this patient's got diaphyseal. Okay, this patient is complaining of hip pain. Any thoughts? Yeah, there's an impacted fracture of the right femoral neck. Okay, so we've lost Shenton's line. The femoral neck has been rammed into the femoral head. The trabecular markings have gone. This is an impacted fracture of the neck of the femur. Okay, this is a Singaporean sailor who docks in Liverpool and presents with a wrist abnormality, pain in the wrist, and then that x-ray. What do you think? Yeah, this is tuberculous arthritis of the wrist, TB of the wrist. And this patient did in fact have primary pulmonary TB, on the chest X-ray. And what happens with tuberculous arthritis of the wrist, you get a profound synovitis, which tends to involve multiple joints, and then you get this almost like an erosive process. While on the left hand, it's hematogenoous, and it's it's a mystery why you get it on the left hand, not on the right hand, but it's a hematogenoous spread of tubercle bacilli, and it's the same reason why when it involves the spine, it may involve one or two vertebrae, but not all the vertebrae. Okay. If it was a septic arthritis, the patient is likely to present earlier and there would be a lot more destruction of one joint, but not of many joints. Okay. The fact that it's involving loads of joints makes TB more likely. Okay, diagnosis. Yeah, simple bone cyst with a pathological fracture. There's the fallen fragment sign. You can see the fracture here. You may or may not see the fallen fragment sign on the AP view, but in this particular patient, you see it on the lateral view. Okay, ignore those surgical clips because the X-ray looked very similar on the preoperative film. We've got small bowel dilatation. That looks a bit like gas in the transverse colon, not particularly dilated. But this is small bowel dilatation. We've got dilated small bowel and we've got normal small bowel. Therefore, it's a mechanical obstruction. And the mechanical obstruction is at the umbilicus. So it's an umbilical hernia. Destroyed third rib, just there. The posterior rib has gone. So whenever you see this in the exam, an X-ray that looks relatively normal, don't forget to just count the ribs and say to the examiner, it looks relatively normal on first impressions, but I can't exclude any rib pathology. I just want to go through the ribs. But a better answer would be to say, I can't see any obvious abnormality, because that's true. You can't see any obvious abnormality. But if you say it's normal and then I'm just going to look at the ribs, the examiner's going to say, well, is it normal or is it not normal? So a really good approach is to say, on first impressions, I can't see any gross abnormality. And then you need to start looking at the ribs. And this third rib on the right has been destroyed. And then you go through the various causes of metastatic bone destruction. Breast, bronchus, thyroid, kidney. Okay, so that's what you need to do. You need to have that answer already prepared, and in the same sentence, you need to come up with myeloma also. Okay, this is on a small boy who's got hydronephrosis. Yeah, posterior urethral valves, just there. Okay, this patient has got grade 4 reflux into the left kidney. Spot diagnosis. Yeah, Pectus excavatum. So we've got an obscuration of the right heart border and the horizontal posterior ribs. They're not that horizontal really, but classically they're supposed to be more horizontally orientated. And the patient, the rib will have almost a figure of 7 configuration. So like this. I've exaggerated the horizontal nature of the posterior rib, but that's what it's supposed to look like. Now, what you don't want to do in this situation is to confirm it with a lateral film. What you do want to do is you want to examine the patient clinically. Now, quite often, you will not be able to examine the patient because the patient left the department, but it needs to go in your report so that you can encourage the GP or the referring clinician to examine the patient. Now, if it's middle lobe consolidation or collapse, it could look the same, but you wouldn't have the orientation of the posterior and anterior ribs. The other thing that isn't really written about in the books is because pectus causes a shallow depression on the front of the chest, the breasts get closer together. Okay, so the breasts get closer together. Okay, what have we got here? Patient is complaining of a cough and loss of appetite. Yeah, the Nuss procedure is associated with a Lorenz bar. Yeah, there's a right lower lobe lesion here. Yeah, and that was a carcinoma. Sorry, that's that third rib lesion. This has appeared twice. Okay, you saw a cecal volvulus, and this is now a sigmoid volvulus. And the reason why this is a sigmoid volvulus is, even though I may not be able to see the cecum, I think the cecum is probably here with feces in. But this is the sigmoid volvulus, okay? I'm just going to draw some of the perimeter, but it's overlapping a dilated descending colon, which is here. And you wouldn't get that with a cecal volvulus. So this is a sigmoid volvulus. Okay, barium small bowel meal in a patient with acute on chronic abdominal pain. Any thoughts? It's not malrotation, but there is more small bowel on the right than there should be. Yet there's something pushing the bowel, and that something has got a lucency. So, any thoughts? It's actually an abscess. So here's the stomach. There's transverse colon. Sorry, I beg your pardon. Start again. Um, there's the stomach. There's the splenic flexure. There's the patic flexure. There's the jejunum. There's the ileum. And then here is an abscess. And that abscess is almost certainly going to be in the lesser sac. Okay, so it's a lesser sac abscess which is pushing the stomach and the small bowel over to the right. And that's what that patient had. Okay, what's going on here? Yeah, so we've got a malpositioned ET tube. So there's the carina. There's the ET tube just there. And it should really be at least 2.5 centimeters from the carina. Okay, so it needs pulling back, and we've already got consolidation and partial collapse in the right lower lobe. We've got a small pleural effusion and consolidation in the left lower lobe. Okay, so that needs to be communicated immediately, and it's really important that you indicate to the examiner that you're going to pick the phone up and speak to ITU. It's one of those things that needs an urgent communication. On the edge enhanced film, you can see again, it's a bit more clear, and actually the tube is there. So that illustrates a really nice point. I thought the edge of the tube was there, but actually when we do the edge enhanced film, it's lower. So this is the purpose of the edge enhanced film, and this clearly needs to be communicated to the ITU staff. Okay, this patient presents with a stroke. Yeah, left ventricular aneurysm just here. And that obviously contains clot, which gets flicked off and goes into the systemic arterial tree. There it is on the CT, and you can see thrombus against the wall of that calcified left ventricular aneurysm. You get left ventricular aneurysms because the patient has had a myocardial infarct in that part of the myocardium. Okay, this patient presents with pelvic pain. There's a left lytic lesion on the left iliac bone. Sorry, inferior ramus. No, yeah. So Amal Shaker has got it right. It's an iliac wing lesion. So look at the cortex here, and look at the cortex there. We've got a permissive lesion, and we've got loss of the bone trabeculation just here. So this patient has got a destructive bone lesion, and that can either be due to a metastasis from breast, bronchus, thyroid, or kidney, or myeloma. Okay. Okay. The F2 doctor came down and asked me to do a biopsy of this mass lesion. What do you think? Yeah, insisted pseudotumor in the oblique fissure. You can see some curly B lines here, some blunting of the CP angle here and here, and upper lobe blood diversion. So this patient has got cardiac failure, and the circumstantial evidence of cardiac disease is this pacemaker. And when the patient has diuretics, this lesion disappears. Now, when we look at this lesion, you can see that it has the incomplete border sign. So what I mean by that is it's very sharp here, it's very sharp there, and then it fades here. It fades there. Okay, and that's called the incomplete border sign, and it tells you that this lesion is likely to be outside of the pulmonary parenchyma, and in this case in the pleura. Okay. So it's the incomplete border sign, very important to recognize that, because you can then say that this is in the pleura, not in the lung. And it disappears when treated with diuretics. Okay, this patient presents with abdo pain. Yeah, AAA, well done. There's the edge of the aneurysm. And that's a really big aneurysm. Note also we've got complete loss of joint space in both both hip joints, with femoral head distortion, probably secondary avascular necrosis. There's the stomach bubble, and this is a very large aneurysm. Okay, spot diagnosis here. Left lower lobe collapse. Yeah, well done. There it is. The sail, shadow behind the heart. Left lower lobe collapse. Okay, what is causing this increased opacification of the left hemithorax? Trauma. Yeah, so it's a supine film. It's a pleural effusion, and because of trauma, this is a collar, a halo collar for a neck injury. This is likely to be due to a hemothorax. Okay, but in essence, it's a pleural effusion in a supine patient. Okay, so let's go to day 2. So day 2 after the trauma, what's happened? No, it's not a pneumatocoel. Let's go back to, that's an erect chest x-ray. That's a supine chest x-ray. So we've got fluid in the pleural space, which is obviously tracking posteriorly because it's supine. And then the next day on the erect chest x-ray, we've got this bubble. Yeah, there must be a hernia in the left hemidiaphragm. So it's a traumatic hernia, laceration of the diaphragm, ruptured diaphragm, whatever you want to call it. And this is the stomach or the colon. Okay, could be the stomach or the colon. If you see a haustral fold, it's the colon. But if you don't see a haustral fold, it could be the stomach. And this is the CT of that patient. And actually, that's a haustral fold. There, there, there. And this was a stomach. And a colon in the chest. There's the hemothorax. And when we do the CT, you can see there's a rent in the diaphragm, and both the stomach and the colon have gone into the chest. So ruptured left hemidiaphragm. Okay, what is the diagnosis here? You sometimes get this in the viva. Not achondroplasia, not Blount's disease, not thalassemia. Splaying of the metaphyses, widening of the growth plate. Okay, that's a close-up. You get ill-defined, non-mineralized cortex. Okay. You get a spur formation. So spur is here. Okay. You get widening of the growth plate. So this thing here is widened. And you get fraying of the metaphyses. So it's all a bit ragged. Okay. And this is rickets. So you need to just remember rickets. Ill-defined cortex, widening of the growth plate, metaphyseal fraying, that just means irregularity, and splaying and spur formation, rickets. Whereas this one, we've got a dense zone of provisional calcification. We've got almost like a pencil drawing around the epiphysis. That's called Wimberger's sign. And then we've got what's called a Pelkin spur, just there. And this is scurvy. Okay, so we've got scurvy, and then the other thing is we've got a lucency just proximal and distal to the dense zone of provisional calcification. That's called a Trümmerfeld zone. Trümmerfeld zone. Okay, so just understand what sort of images you might get in the exam. Okay, so scurvy, fairly straightforward. Don't forget also you can get very large subperiosteal hemorrhages with scurvy because of lack of vitamin C. And here's one. So it's a subperiosteal hemorrhage which is calcified, and we've got all the changes. There's Trümmerfeld's zones, which is proximal and distal to the zone of provisional calcification. More periosteal hemorrhage, which I've drawn there. As a really severe case of scurvy. Okay, oh, this is just a bit of fun, really. This patient has had a chest x-ray, and what I want people to look for is what is going on here. Nope. That says, that's an apostrophe. That's a T. Can't see the I, but that's an S. So that's it's, the. Can't see the H, but that's an E. And that's an M-O-S-T. It's a Christmas jumper. It's the most wonderful time of the year. Okay, it's a Christmas jumper. I put it in just for a bit of fun, really. Okay, so I'll just erase all those things. And can you see the S? There's the T. Can't see the H. There's the E. M-O-S-T. Christmas jumper. Bizarre. And that's the chest x-ray with the jumper taken off. Okay, I'm just going to put that link in again. Just anyone who's just joined, we've done a chest course. It's really comprehensive. You'll absolutely love it. There's 106 lessons, and it will take you well beyond the FRCR2B. So it will ensure that you're going to pass the chest section in the exam, but it'll take you beyond that. For anyone who's an interest in chest radiology. Now, the chest course, it's an online course. It's already prepared. All you do is you go onto the landing page, you purchase it, and then um, we then you'll be able to see it. Okay, so it's already prepared. We've got lots of videos, lots of lessons, lots of images, lots of explanations, and it's £79.99. Okay, so this is a young lady who presented with back pain. She was 23 years of age and she had just left university. That was her chest x-ray, which shows a pleural effusion and what looks like trapped lung. Okay, so yeah, this is primary pulmonary tuberculosis. And the reason why the patient has got back pain is that they've got tuberculous spondylitis. Tuberculous spondylitis. And it's causing a pleural effusion on that right hand side. There's an epidural mass, which is causing the back pain, which you can see here and here. And what happens with TB spondylitis is that you get destruction of the vertebrae with minimal destruction of the disc. And that's what we're seeing here. Okay. Minimal destruction of that disc. And what happens is in TB, the infection grows underneath the ligament and it jumps from one vertebra to another. And this is the CT reconstruction. We've got destruction of the vertebra, and then we've got a relatively normal looking end plate. Now, if that was due to a pyogenic destruction, the end plates would be ragged like this, and then we'd lose disc space. So that would get closer together. You get disc space narrowing, it'd all be ragged. But here, it's almost like the infection has jumped underneath the ligament from one vertebra to the other. And here's the pleural effusion. Don't forget, primary pulmonary TB is associated with the pleural effusion. Okay, so pleural effusion here. I'll just erase all the ink so you can see that better. There's the pleural effusion. Here is rounded atelectasis as part of that exudative pleural effusion that's trapping the lung, and then clearly the patient's got tuberculous spondylitis. Okay, this patient presents with a pathological fracture of the humerus. What's the underlying cause? Yeah, lung cancer. So there is a lung lesion in the right upper lobe, just here. Okay, lung lesion, and there's the chest X-ray with that lung lesion just there. Okay, this is a really, really unusual case. I've never seen a case like this before, and it was kindly given to me by Dr. Jaspreet Singh from Malaysia. And I want people to tell me what they think it is. Not tuberosclerosis. Can you see that one side of the brain is involved and the other side is not? Yep, so this is very vascular on that side, not so vascular on that side. That's on CT. We've got sulcal effacement on that side. That side is normal. And then we've got this abnormality on the right-hand side on MR, but not on the left. Any thoughts? Rasmussen encephalitis, well done. Rasmussen encephalitis, also known as chronic focal encephalitis, and it's a kind of inflammatory process which is long-standing, and it affects one hemisphere. Okay, I think it's idiopathic. People really don't know what causes it, and they present with status epilepticus or epilepsy. Okay, and it's very unusual. And it's a bit similar to other types of encephalitis in that they get a lymphocytic infiltration in the CSF. But it's really quite bizarre. So if you see something like that, just say, I've seen this before with Rasmussen's encephalitis. I think you're most unlikely to get it, but if you do, knock it for 6. Okay, what is the diagnosis here? Trauma. Yeah, radial head dislocation, well done. So here's the radial head dislocation. There's the capitellum, and the radial head is dislocated. There it is. There's the radial head, which should be articulating with the capitellum just there. So it's dislocated. What can you see there? The diagnosis of the brain was Rasmussen's encephalitis. Yeah, we've got sclerotic bones. This is osteopetrosis. There's no injury actually. The ribs are also sclerotic. The thoracic and cervical vertebrae are sclerotic. What's that sign called? Honda sign, and it's a sign of an insufficiency fracture in the sacrum. Excuse me. And here it is on the MRI. So we've got increased signal, and in effect, what happens is you get a horizontal and a vertical component of that fracture. So causes are osteomalacia and osteoporosis. Okay, this patient has got backache. Any thoughts? Yeah, there's something eating away at the bone up here, and there's a difference in density between the right apex and the left apex. So it's entirely possible that this could be a Pancoast tumour. And in fact, it was a Pancoast tumour involving the rib, which has gone. That rib has gone. So we've got 2 ribs gone, second and third ribs, and this is eating away at the vertebrae, and we've got this increased density up here. So the pedicles have gone on the left-hand side for those 2 contiguous vertebrae. Okay, so we've got a crescent sign here, a crescent sign here, and a crescent sign here in a patient who's got a tunneled catheter. So what's this one? Yeah, invasive aspergillomas. And when you get a healing phase from angioinvasive aspergilloma, you then get a classical crescent sign. So an crescent sign can be seen in somebody who's got invasive aspergillosis and they are immunocompromised, or somebody who is not immunocompromised but has got aspergillomata. Okay, but this is a kind of it's a response to treatment in somebody who's immunocompromised and has got angioinvasive aspergillosis. Okay, what's the diagnosis here? Yeah, so we've got meningioma here, possibly a meningioma along here, and then bilateral acoustic neuromas. So this is a neurofibromatosis type 2. Okay, what's going on here? Yeah, so we've got a Charcot's arthropathy. You can see uh, digital vascular calcification, and we've got a Charcot's arthropathy developing just here. Okay, it's not actually a Lisfranc in the sense that the metatarsals and the tarsals are dissociated, but there is some form of dislocation and subluxation of the tarsal joints in a patient with Charcot's arthropathy. This is a severe case of Pectus excavatum, and this patient did have a CT scan, okay, and that just shows you the extent of that Pectus excavatum. But what I really want you to show you is, as well as this patient having Pectus excavatum, they've got something else on the film. They've got a left apical tumor. They've got a pancreas tumor. Okay, so as well as having a Pectus excavatum, they've got a pancreas tumor. Okay, and there it is there, and there it is there, destroying the rib. So this patient has got a pancreas tumor, and this is clearly something that you could miss on the film because you are concentrating on the Pectus excavatum. Yeah. So it's very important that you look at everything and tell the examiner you're keeping on looking so that you can work out uh, any other pathology that's going on. So it's 6:30. I understand that Dr. Khan has got his course, and people will want to go and join him on that. Um, thank you for your attention. Very good luck for anyone who's doing the exam tomorrow. Please, please, please have a look at the chess course, which I've just put in the chat again. I think you'll like it, and I'm going to leave you with The Flood by Josh Hislop, and I'll see you on Monday.